This morning, it is indeed my privilege to introduce Dr. John Clarke. He's currently the Clinical Associate Professor of Medicine and the Director of the Esophageal Program in the Department of Medicine at Stanford University School of Medicine, which also means that he's up ultra early here to talk with us, which we truly acknowledge and appreciate. Prior to this, he was the Director of Esophageal Motility and the Director of Gastrointestinal Motility and the Clinical Director of the Johns Hopkins Center for Neurogastroenterology, and also the Clinical Director of the Gastroenterology and Hepatology Division at the Johns Hopkins Bayview Medical Center. While at Johns Hopkins University, he was inducted into the Miller-Colson Academy for Clinical Excellence, which is an institutional honor society for master clinicians. He subsequently joined Stanford University in 2016 as the director of the esophageal program, and his clinical and research interests include the spectrum of esophageal and gastric motility disorders, as well as GI manifestations of systemic disorders such as scleroderma and amyloidosis. His research is really focused on optimization and characterization of diagnostic studies to evaluate motility disorders, as well as the relationship between therapeutic endoscopic techniques and treatment of motility disorders. He was an investigator on the NIH Gastroparesis Consortium, and he's also a former recipient of the A.J. Don Castell Award. So this morning, we truly regret that you are not here with us and we can't host you in person, but nonetheless, we are really pleased to have you here to bring us the latest on the diagnosis and management of gastroparesis. So thank you again, Dr. Clarke, for coming.
Well, thank you. Appreciate it. That was the best introduction I've heard of myself, I think, ever. So thank you very much. It'll take me a second just to load up my slides here, but I lived back in New York City at medical school in the late 90s. I graduated back in 1999, and I recall it as being an absolutely wonderful place to live. So I'm sorry I'm here now and I'm not visiting this morning in person. But thank you very much. And it's my privilege to talk about gastroparesis and talk a little bit about diagnosis and management. And what I'm going to do in the next 45 minutes or so is to go through a case just to set the background, talk about the burden of gastroparesis, talk about what we currently know at this point about physiology, talk about diagnostic options, treatment options, and I'll briefly look through what we have. Then I'll talk about what's new in the last 5 years and what's in the future. I'm going to spend some time in particular discussing the pylorus, since that's a hot area at the moment, and then I'll stop with the unanswered questions in future directions. To start off, I'd like to go through a case that I think illustrates some of the complexity of these patients, as well as some of the options that we have. This is a 24-year-old woman who I saw in 2009, and she came in with vomiting, which had been recurrent. And excuse me, my screen seems to be on a timer, so I'm going to just see if I can shift that and start this again. Okay, so hopefully this will work better. She had been scheduled to be seen in clinic the following week, but couldn't make it and came towards the ER. Her symptoms had started at age 15. She had nausea most days of the week, but on a good week, she'd vomit 3 or 4 times. Then she had these intermittent flares where she would vomit profusely and would then have hospital admissions. And she'd had 40 admissions within the past decade before seeing me. Her past medical history was interesting in that she had diabetes with an insulin pump, but she was diagnosed at 18 and her GI symptoms had started actually at 15, and she'd always been well controlled throughout the whole time period. She had asthma plus depression, Phenergan, plus Benadryl and SSRI. She was a PhD student, married, didn't have any vices. Her treatment history, not surprising with 40 admissions, had been pretty extensive. She had attempted erythromycin, metoclopramide, domperidone, tegaserod, multiple meds to try and treat the vomiting per se. The bottom line is that none of these had really worked to any appreciable benefit. She had 6 gastric emptying studies, multiple endoscopies, imaging studies. I'd seen at least 5 different GI doctors. And when we first saw her, she couldn't stop vomiting. She was admitted. She had a CAT scan in the ER, which is kind of at this point a It seems a given for every visit. She had also an endoscopy, which was normal. She had a gastric emptying study, which was vomiting in the first attempt. Second was slow at 2 and 4 hours. And she was symptomatic. And so we at that point discussed, do we do a different prokinetic? Do we look at a G or J tube placement? She said 40 admissions. Do we do a Botox injection? Do we do a stimulator placement or else pyloroplasty? And after a lot of different discussion, we ended up doing a Botox injection. I'll talk a little bit more about literature with that in a talk later. We also attempted nortriptyline, ginger, and she went home, but she came back about 2 weeks afterwards. At that point, she had an ultrasound, labs, CAT scan. She also had a technetium high scan as well, which showed a decreased ejection fraction to 13. So again, we saw her and wrestled with the question of, do we do Botox again? Do we do a G or J tube? Do we do a stimulator? Do we do a pyloroplasty? Do we do a cholecystectomy? Or potentially a combo of those. And we, at this point, wrestled with the issue, decided that we would do a stimulator plus a cholecystectomy. This was back in 2009. She had insurance issues and had 2 additional hospital admissions. And finally got this done, woke up and said her symptoms were gone. And interestingly, the next admission she had was 2 years afterwards when she gave birth, but she had no admissions again until 2016. And we had thought, well, possibly this was just the cholecystectomy then, but it turned out her next admission was in 2016 when her battery went dead. So I think she's a good example of someone who responded dramatically towards stimulation. Personally, I've probably done about 75 of these, and I've never had anyone else that had this response this good. So I certainly don't want to say that this is normal, but in some patients, this works very well, and I think it illustrates the complexity of these cases. So I'll talk next about burden of gastroparesis. And I thought this picture was particularly relevant based on the month and Halloween coming up. But this is what we tend to see and think about with gastroparesis. This is derived from the Greek words gastro plus paresis, meaning partial, meaning paralysis of the stomach. And it's really defined as delayed gastric emptying in the absence of any mechanical obstruction, linked with one of these symptoms, getting full quickly, a sense of feeling nauseous, bloating, etc. Yeah, to meet this criteria, you have to have impaired gastric emptying. And so if you have these symptoms without gastric emptying delay, this is referred to at this point as functional dyspepsia. It's thought to have a prevalence within the US of less than 2%, and we've seen increased hospital admissions within the last decade. This illustrates, you can see a rise in hospital admissions really beginning in about 2000. That's been pretty significant. And if you look at the subgroup of this specifically, this appears to be primarily in women who are non-diabetic. And why this group appears to be increasing selectively is not clear. There is a link as well with decreased mortality in gastroparesis, and it does appear that the 5-year survival is less in those who carry this diagnosis than those that don't. Risk factors that are in particular associated with worse outcomes are diabetes, male, and age. Now, what do we know about physiology? And this is complex. So we often don't talk about gastroparesis being symptoms with impaired gastric emptying, but impaired gastric emptying is not the only mechanism that's at play. And if we look at what the stomach does, there's a number of other different pathways which can potentially go wrong. And so essentially there's a thought that some symptoms might be secondary to decreased motility in the fundus, and so there's less accommodation. Some might be secondary to potential weakness within the antrum, less grinding and breakdown of food, possibly pyloric obstruction or spasm, gastric dysrhythmia, or possibly feedback mechanisms from the small bowel which are excessive. Bottom line is that it's probably not the same mechanism for each person. And what we're probably seeing is a hodgepodge of different defects that end up linking with common symptoms. And I like to think of this as almost akin towards irritable bowel, where we really define this based on symptoms and improper tests. And we really have a hodgepodge of different disorders that right now we lump in one bucket. And probably in 15, 20 years, when we have better technology and can really decipher these into different buckets, we may not characterize them in one umbrella. But right now, this is what what we have. If we also look at the way that the innervation works in the gastrointestinal tract, it's reasonably complex. And so we have innervation from the vagus, we have spinal stimulants, and then that's all linked entirely with central control. The gut has 500 million neurons which are associated with it, which is actually as many as the spinal cord. And so, not surprisingly, a number of defects in that area can often lead towards symptoms which are pretty profound. If we then look at neuromuscular dysfunction within the gastrointestinal tract, it's not even as simple as one pathway there. We have the enteric system, we have the extrinsic system, and then as well we have smooth muscle dysfunction. So steps can go wrong anywhere in these pathways, and the ultimate manifestations might be similar. If we look at the causes, I think reinforcing again that this is really a hodgepodge of different disorders. The most common we see right now is idiopathic, but diabetic is a close second. And then there's a number of other different systemic disorders which are associated with it. And it's not hard to think that once we can really distill the underlying mechanisms, someone that comes with gastroparesis with Parkinson's disease is probably going to be very, very different than someone that comes in that's 20 without any systemic disorder. So, to step back and look at physiology, multiple mechanisms at play, likely not the same pathway for each person. And we're currently in this diagnostic conundrum where we're saying that the definition of gastroparesis will hinge upon slower gastric emptying, but there's really not good data to show that impaired gastric emptying is the cause of symptoms. This is one of my favorite studies, which was done about a decade ago at this point, where they looked at symptom burden based on gastric emptying. And this is about as negative a scatter plot as you'll ever see. And so while we do say that you have to have impaired gastric emptying, there's no literature that gastric emptying necessarily will induce the symptoms. It's not necessarily linked with symptom severity. And if you look at patients who are in individual trials who get better with prokinetics, there's also no correlation between the change that they have in gastric emptying and also what happens with symptoms. So probably gastric emptying is an epiphenomenon of gastric dysfunction, but it's not a great marker, and it's probably not the cause of symptoms. And again, this goes back to the point that we have multiple different pathways at play, and it's probably not the same pathway for each person. And this also brings up the point which we'll get to, is that when we look at treatment trials, it's probably unrealistic to think that if you take all comers with gastroparesis and you put them in a trial and look at a med that has one mechanism, that you're going to see a giant response, because these aren't really a monolith. Now let's talk about diagnosis. And in this section, what I'm going to do, I'm going to talk about gastric emptying assessments. I'll then talk about other diagnostic options that we have to look at gastric function, and then some new developments which are interesting. We have 3 methods right now that are FDA approved looking at gastric emptying. The first one is scintigraphy, and this has really become the current gold standard at present. There was a joint consensus of, at that point, the ANMS and then also the Nuclear Med Society in 2008, which recommends a 4-hour study. And this is currently at the mainstay. Now, there's 2 other options which are FDA approved. The first one is wireless motility capsule, which is also referred to as smart pill. This is an interesting study where a capsule that looks at temperature, pH, and pressure is ingested, and then you, at that point, record parameters for about 5 days afterwards. And this is a way of looking at gastric emptying plus small and large bowel. Nice thing about this is that you also get information about other areas within the gastrointestinal tract besides stomach. You also look at pressure, which you don't get from scintigraphy. Downside of this is that insurance is a bit of a challenge. And it's not necessarily clear that the swallowing of an ingestible solid is the same as with a meal. So sometimes it's not quite an apples to apples comparison. I'll say in my institution, we do mostly scintigraphy, because of insurance issues. We probably do about, I'd say this about 75 a year, but it's interesting at our site, at least, the cost of doing this is about 1/3 the cost of getting scintigraphy. The newer one that's out that's FDA approved right now is the C13 breath test, and this was approved in 2016. It's cheaper than the others, hasn't really caught on as much, and I think part of that is that the way it currently works is that you have to get this test done within a specialized site that can make up the meal, do breath samples, then send them to a processing lab, which is in Tennessee. So it's a little bit tough to do, and it's hard to make a real reimbursement with this as well, because the processing is done elsewhere. But where I think this is helpful is that if you're doing clinical trials, this is definitely the cheapest of all of these. So it's a good option. The one limitation with this is that it really relies upon absorption from the small bowel. So if you have a pan-gastrointestinal dysmotility, or if you have small intestinal bacterial overgrowth, which are commonly seen with gastroparesis, then you do have to take that into account when looking at this information. Now, let's talk a little bit about some of the other tests that are out there that look at gastric physiology without looking at gastric emptying per se. This is the intraduodenal manometry, which is done less often now than what it was about 20 years ago. The idea here is that you can look at both motility and coordination within the stomach and small bowel, and it is a way of potentially separating myopathy and neuropathy. Now, the challenge with it is that there's not great data that the information that you get from this study necessarily predicts the outcome with therapy, and it's pretty cumbersome. Typically, it's done with endoscopy. You then have to keep this catheter in for about 6 to 8 hours afterwards. You have to have a nurse or tech who's really trained well enough to make sure the catheter doesn't move. Has to have fluoro with it. Reimbursement is reasonably low. So it's a lot of hassle for something that at the end of the day might not change next steps in terms of what to do. The next one that I think is new that's interesting is FLIP. And this is actually a story that's being told. And so this is a FDA-approved technology that was approved in 2010 that looks at diameter and extensibility, and it's really gained traction mostly in the esophagus. But there's been 4 papers so far that have looked at this specifically in the pylorus. And the idea is that if you can gauge extensibility and diameter in the pylorus, maybe you can use that as a predictor of which patients are going to benefit from therapy that's directed towards that area. I think we're at a point now where we have identified that there are different subsets of patients within gastroparesis, but there's not yet good literature that being in one of those subsets predicts response towards therapy. I think we'll see more information coming out on that. So something that's interesting to keep an eye on. One of the challenges logistically with this is that getting the FLIP catheter across the pylorus is not as simple as it is in the esophagus, and there's a lot of movement back and forth with the catheter. The catheter design right now makes it such that as you start inflating, it's somewhat challenging to keep it in traction there. There is as well paper that's coming out looking at FLIP motility as also a potential way to look at not just extensibility, but also potentially contractions in the area too. The last one is just to briefly round out discussion. Electrogastrography is almost like an EKG looking at the stomach. And this is something that was in use about 30 years ago and kind of fell out of vogue with the idea that we don't have good literature showing that what you see with this necessarily predicts response towards therapy. It does take about 3 hours to do. It's not reimbursed in most centers. So at the end of the day, it became more of a research tool and less clinical. Get back up again. But there's been some change with that recently. And the group at UCSD just released a paper last year looking at high definition mapping. And at least in their series, there did appear to be better correlation with the high res electrogastrography than what we saw with conventional. And at least in their series, the symptom correlation was better with this than with gastric emptying. So where this goes in the future, we'll see. But it's potentially a good option in that it's non-invasive. And it does make sense, just if we step back intuitively. If you take a look at cardiology, the field has an entire area that's geared towards physiology and towards cardiac rhythms. And we know that the stomach and the gastrointestinal system has a massive amount of nerves there, and there have been shown to be reentry dysfunction as well as other pathways potentially which are aberrant. So it does make sense that there's probably more towards gastric physiology than just the rate of contractions per second and per minute. So I think this bears keeping an eye on. And then to jump towards the bottom, deep tissue biopsies are, I think, a fascinating next step as well to keep an eye on. As we've had better tunneling techniques, we're now getting different centers that are looking at pathology with gastroparesis. And the bottom line is that there are distinct differences with histology within subgroups. There are some that have pathology that looks normal. There's some that have mast cells which are aberrant. Different pathways which are seen. There's not yet data that suggests that the findings that you see in pathology are going to predict response towards therapy, but this is a reasonably new field at present. I think that information will come. In the future, though, you can envision a scenario where if you could do a deep tunneling biopsy, get biopsies from both the muscle and the sub-Q space, characterize these patients within different buckets. And if you see a difference in outcomes based on that, these may then become predictors of who actually responds towards different therapies. Now, to talk next about treatment, we have a couple different options which are here, and I'm going to do one slide that just talks about what's currently done. And then I'm going to focus, just in the interest of time, upon meds which are new, upon complementary therapies, pyloric directed therapies, which is really a very, very hot topic now. And then last I'll touch base on gastric stimulation. So this is the current list of what we have at present. And when I see a patient in clinic, we sit down and we talk about options, this is really the list that we go through. In terms of a lifestyle modification, it's often the first step. And what's done there are small meals, more supplements, low particle liquid supplements in that area. But the goal is really to try and to minimize the work that the stomach does and also minimize distension. In terms of medical therapy, we have 4 general pathways which we go down. The antiemetics work in terms of symptom control. They don't necessarily affect gastric emptying, but they're reasonable to try and treat the dominant symptom. Prokinetics operate with the assumption that increasing gastric emptying may help in terms of symptoms, but as I said before, there's not great literature that that's necessarily the case. Those prokinetics that have the best data, such as domperidone, for instance, also have an antiemetic component that's quite prominent. And it's really unclear if the benefit that we see in terms of symptom improvement is from the emptying per se, or if this is just secondary to improvement within their symptoms. If we look at this list of what's here as prokinetics, it's important to note that the only med that is FDA approved right now in the US for gastroparesis per se is clopramide. And in this list, everything else that we do is not FDA approved for this. If we look at domperidone, for instance, this is a drug that's not FDA approved at all in the US, but you can write for it if you do an IND application with the FDA that's linked with an IRB in your own institution. And so there is a way of doing it, which is government sanctioned, but it's really a pain. And so if we go down towards the next bucket, there's been some recent interest within buspirone, and this is based on papers that came out of Belgium. The idea is that this works through 5-HT1, which is largely expressed within the upper stomach, lower esophagus, and it does appear to help accommodation. and at least in 2 papers, for that sense of getting full very quickly, it does help in that area. I can say my personal clinical experience with it hasn't been as good as what the papers are. So my sense is that this may be an option for very particular patients with possible deficits in that area, but I haven't been that personally impressed with it so far. There's been a lot of interest in doing medications that are going to essentially desensitize the gut. And so tricyclics plus mirtazapine, SSRIs, SNRIs. Again, the data hasn't been terribly good. There was one randomized control trial looking at nortriptyline, which was performed about a decade ago from the Gastroparesis Consortium. Bottom line is that it didn't meet the primary endpoint, though there were a couple subgroups that may have gotten benefit. I won't talk here as much about complementary therapies, just because I do have a section on that as well later. And then same, in fact, with the endoscopy as well as operations. I'll talk about those in slides to come. Now, there's no great consensus. This is a paper we're hoping to get submitted within the next month, but we had polled 48 experts internationally in gastroparesis to see what they use, what they think is supported with literature, and what they think works in their own patients. The bottom line is that it's all across the board. And there's no one thing that everyone agrees definitely works. The ones that had the best concordance were domperidone and Reglan. But you can see with everything else here, some do, but not consistently. Same thing with procedures, where the one that people felt worked the best was actually J-tube placement. But that's certainly not something which we'd push for everyone. Botox injection was fascinating in that most people don't think the data is very good, but also most people use it, which fits. And then looking at GPOM as well, most people don't think the data, at least last year, was that great, but more of them use it than think works. And we'll talk about that a little bit more. In terms of the new medical options, there's 3 categories which are out there. The first is NK1, and the idea with this is that this is involved in the central processing of symptoms, specifically of vomiting. And it's via a different mechanism than what we've used prior in terms of drugs. This kind of came on the map with aprepitant, and this is the APRON study, which was published in 2018. And in this particular study, the Gastroparesis Consortium looked at patients who had nausea, 2/3 of whom had gastric emptying impairments as well, 1/3 didn't. And the bottom line is that the primary endpoint was not met. But if you did look at symptom scores, it did appear to improve things significantly in terms of vomiting, as well as that subset of scores. The challenge with aprepitant is that safety seems reasonably good, but it's about $80 a tablet. So if it's often a battle with insurance, where we often will use it are for those people who are inpatients, where they have flares, and we're looking for something to possibly break that cycle. It can help in that scenario. And I have a few patients where, because of the number of admissions they've had, we've gotten coverage from insurance to get this. But because of the cost, right now it's a real challenge to use. The next one that's out is tradipitant, which had a phase 2 study that looked reasonably good. We'll see where this goes in phase 3. The next category are the 5-HT4 meds, and these are interesting. Cisapride was in this category, and these are prokinetics that work in not just the stomach, but also the small and large bowel. And cisapride probably had the best literature of any of the prokinetics with the gastroparesis, but it had significant cardiac issues, and it was pulled from the market 21 years back. Prucalopride, it was FDA approved in 2018. It was prior to that it was approved in Europe in 2012, and it's thought to be a similar mechanism towards cisapride without the cardiac risk factors associated with it. Safety seems quite good. There was one study that looked at this in a gastroparesis from Jan tox group back in Europe. And the bottom line is that it did appear to improve both symptoms and gastric emptying within a small study. We'll see where this goes within studies which are larger, but we've liked this med in our practice. And the reason for that is that safety seems good. It's got at least some literature supporting use in a gastroparesis specifically. Mechanistically, it's similar to cisapride, which had good literature in the past. And it seems to be safe. And so when we're talking with patients about what we can do as a prokinetic if they want to go in that direction, and we're looking at this versus Reglan, there's probably better literature with Reglan, but given safety concerns, most patients are opting to start this, I'd say, especially if they have constipation as well. The next one, that is Volusitrag. This had a phase 2 study that looked reasonably good with both improvement in symptoms and gastric emptying. The rights have been sold to a different study, a group, and we'll see where this goes in phase 3. Ghrelin is fascinating, and we do know that ghrelin has a link with weight, gastric motility, as well as symptoms. One interesting point that's been raised, and there's not really a good explanation for it, is that about a third of patients we see with gastroparesis are technically obese. And if you think about it, these are patients who are vomiting, who don't keep a lot down. And one school of thought is maybe because of vomiting, they've changed their diet to be foods which are better absorbed, which are less healthy, and that's why. But there's also, we've seen, at least in our group, that we have some patients who are obese who don't lose weight despite minimal caloric intake. And ghrelin may potentially play a role in that. And so relomorelin is the first drug which is coming to market with that. This is the phase 2 study, and it did appear to improve both symptoms and gastric emptying. The phase 3 is en route now. I'll just mention that this has really been championed from the Mayo Group, and in this paper, Dr. Camilleri, who I'd say is really one of the leaders in this field, who has pioneered a lot of this, he said that this med is the one that he personally is most enthused about within the years to come. So I think it's something to keep an eye on. Safety seems good. At least this is a nice study with results that look good, and it seems like this is also a newer mechanism as well. So then last, pain is increased with gastroparesis. And this is a point that has probably been present throughout, but has been more recently identified. The gastroparesis questionnaires, which are used in research, are referred to as the GCSI. And interestingly, it doesn't ask about pain at all. It's nine separate questions which are asked. It asks about nausea, about being full. It doesn't ask anywhere about pain. But if you look at the gastroparesis consortium studies, which have been done in the last decade, pain appears to be the second most common symptom that's seen with gastroparesis. And there's a number of different pathways that can take place by, peripheral and central. And because of that, there's a number of different meds that have been tried in case reports and small series. I've listed most of them here, as well as other areas which are being looked at. I think this is a field in motion, but if you do have a gastroparesis patient who does have pain needs specifically, this is kind of the bucket which is possible to choose from. Now let's talk about some of the complementary therapies, and this is a area that I'll say in my clinic we do talk about a lot. And part of that is that I'm outside of San Francisco, and so patients in this area generally enjoy these. But part of it is also that when you talk with patients with gastroparesis, and like a lot that we see, gastroparesis is a spectrum. And so when I'd been a fellow, for instance, I thought everyone with Crohn's had horrible fistula and very, very, very challenging courses. And then I saw more patients in a clinic second and third year, and I realized that that's really the tip of the iceberg, and that most people do very well with therapy and have more of a mild course. That's like gastroparesis. Most people that we see in clinic, generally do pretty well, and the subset that are getting hospitalized is really, again, just the tip of the iceberg. And so when we're talking with patients, and they're, they are symptomatic and they want something to be done. And then you talk with them about the options and say, well, we've got this one FDA approved med, but it can cause tremors, which are irreversible, and, a small subset that take it. And, you have an estimated 60 years of life expectancy left. It does make sense that most people aren't jumping to start these meds. And so this becomes an option for people that want to do something, but want to look at something that's, that's safe, and worst case scenario probably won't make things worse. There's a few options that we have to choose from. Ginger is probably the most intriguing of the top list here. This has been looked at for nausea in pregnancy as well as cancer. It's never been looked at in gastroparesis per se, but it's been shown to speed gastric emptying in mice, rats, as well as healthy people who don't have gastroparesis. So there's at least a basis in terms of a mechanism for where this might work. Safety's good. Going down and looking at the second bucket here, these are blends of different herbs. And I'll say the one that we use the most here is probably the second one down. And this is one that's a mixture of 9 different herbs. It's been in use since approximately the 1960s. It's marketed in Austria, but you can buy it online via Amazon.com. Most health food stores carry it. It's a little bit unclear what the mechanism is, in that it does appear to have an antibacterial effect. There's a little bit of a prokinetic effect. It also relaxes. There's at least one paper which has looked at this within gastroparesis that shows benefit. It's also been looked at in functional dyspepsia and irritable bowel as well. Safety seems pretty good. And so for those patients that want to do something in terms of therapy, but don't want to bite the bullet in terms of a long-term med, these become reasonable options to think about. We've also had some success with acupuncture, and this is something that, again, very similar to herbs. For those people that want to try something that may help, that won't hurt, and do have the insurance coverage or else the means to get this done, this is a reasonable option to think about. The main challenge with this is that we're probably never going to have a large study that looks at this. We tried doing one in about 2013 when I was at Hopkins, and to make this work, you have to have an acupuncturist who gives time, twice a week for a month, an hour for each person. That's generally not reimbursed, and there's not drug trials who are interested in doing this. The NIH doesn't really push this. So unless you have a donor or foundation that gives a massive amount of money, you're probably never going to have a study that's powered enough to say that yes, this definitely works. But at least in the smaller series and case studies that have been done, we do see improvement in about 50% of people. Whether that's genuine or else placebo is tough to tell, but for those that want to do something that may help, that won't hurt, this is also an option that has at least some literature to back it up. Now let's turn gears and talk about the pylorus. And this is really a pretty fascinating area. That's a story that's being told now. The background of this is that some people with gastroparesis may have possibly functional outlet obstruction from the pylorus. And this was first suggested at this point about 25 years back by the group at Mayo when they were doing tests looking at duodenal manometries, and they noticed that there was what they called pylorospasm seen. And there's also been some literature that therapies directed towards the pylorus may improve symptoms within a subset of patients. Now, if we look at the options, we have to go after that. Dilation was the first one employed, but we have a few more now. We have Botox, we have stent placement, pyloroplasty, and then recently GPOM. Botox was first reported 22 years ago, and this had been started looking at achalasia, but with most therapies within the gastrointestinal tract, and I'll say the GPOM is probably the same thing, people start at one sphincter and then they work down. So when this did appear to work in achalasia, there were some bright people who said, well, let's take a look and see if this works elsewhere. And the first case report looking at it in gastroparesis was about 5 years after the achalasia trials. And there were 6 reports that came out that showed improvement in slightly greater than 50% of patients. That led to 2 randomized trials. trials. And first one had 23 patients where they had both Botox as well as sham within a crossover. And the bottom line was that both groups had symptom improvement. Both groups had objective improvement in gastric emptying, but there wasn't any statistical difference between the group that got the Botox and the group that got the saline. There was as well a second study, which was 16 in each arm. They injected 200 units, and they found again that both groups improved in both symptoms and gastric emptying, but there was no change between the two. Now, based on this, the critics of Botox have said, well, if you can't say, if you can't say that this works in 2 randomized trials, we shouldn't recommend this. And we know for a fact that most studies looking at gastroparesis, the rate of placebo response is on average about 30%. Though interestingly, there was one study that showed as high as 70. So we know that there's a giant placebo rate. And so a lot of these case studies, which are uncontrolled, that show benefit in about 50%, it's really hard to separate. Is that placebo? Is it not? And most times you're not just doing the Botox, you're also doing Botox and you're doing hospital admission, you're starting another med at the same time. So critics of this said, well, if you can't say it works versus sham, we should not recommend this. But there have been those people who have said, well, the problem is that the 2 randomized studies that I showed were 23 patients and 16 in each arm. And if you think that Botox may work in the subset that has pyloric dysfunction, then these studies probably weren't powered to see a difference in that group. And so if we look back retrospectively in those who have done more, in Michigan, for instance, very large series, and they reported 51% total. If they used a higher dose of Botox, they had improvement in 3/4. And those who had a first response, about 3/4 of them, responded again towards doing a second one. And so this brings up this conundrum where, people look at the evidence and say the evidence really doesn't justify the use. But the problem is when you have one FDA approved med and you have patients who are getting hospitalized, who are miserable, this becomes an option that we think of with the idea that it may help in some people. The data, of course, is not good, but safety does seem good. And if you don't have other good options to go to, this becomes something which is looked at. There's also some thought that maybe this becomes something that you can use as a predictor. And so if someone gets dramatic improvement with a Botox injection, and you're thinking, well, I might send this patient towards getting pyloroplasty, maybe this is a step that you could use to help guide that choice. We had looked at stent placements, and the thought was that we weren't convinced with the Botox literature, and this was in 2013, and so the GPOM cases hadn't yet started. And we thought, well, if we really want to take the pylorus out of that picture and look to see if opening it up makes a difference, why don't we just stent it? So we did, and we had our first paper looking at 3 patients who got better. We then attempted to do a randomized trial. We ran into obstacles based on funding and the fact that this stent was FDA approved, but not for this. And so we had to do an IND and get funding. And then I moved here. And the bottom line is the whole thing stopped. But during the course of attempting to set the randomized trial up, we did 28 additional patients. We did have 75% improvement. So where I think of stent placement as being an option is if you've got someone who's getting admitted constantly and you're looking for something to salvage, then it becomes an issue. Now, I'll say that because of the other pyloric therapies, which I'll talk about, being at this point readily available, we're not doing this as much anymore. Surgical pyloroplasty has been used at this point for a pretty extensive period of time as a drainage procedure. But what really got this on the map with gastroparesis per se was a paper from the group at Oregon in 2011, and they had impressive results. In 28 patients, they reported reduction in prokinetic use, which was quite significant. Gastric emptying became normalness in a 70%, and they had symptom improvement in 4/5. And there's been 2 additional reports as well that have looked reasonably similar. You know, the challenge with this is that we don't have randomized control studies at this point, and what we really have are single case experiences. There's a group in Texas that I think is approaching this in a fashion that's interesting. And what they've shown is that if you look at gastric stimulator placement, we see improvement in about 50% of people, but we really can't predict who gets better and who doesn't. And if you look at pyloroplasty, you know, we see improvement in at least 50%, if not more, based on these studies. But again, we don't have a great way of predicting who gets benefit and who does not. They're both laparoscopic, so what if you just do both of them at the same time instead of just one? And the group in Texas has now been doing that, and they've at least reported that when they do both of them together, their outcomes are better than when they had done just stimulation separately. But again, we don't have any randomized or else prospective studies at this point. And then there's GPOM. And this is really, you know, I think much like Botox had started with the esophagus and then moved downwards based on sphincters, I think GPOM has been similar. The first report of POM was back in the animal lab in 2007. The first publication in people with achalasia was 2010. The first use of it in gastroparesis was in 2013. And for those that aren't familiar with it, the idea with this is that you're essentially going in with endoscopy, making a submucosal tunnel within the bottom of the stomach, and then cutting the sphincter muscle from the inside. It's got the benefit of essentially doing what you would try to do with a pyloroplasty, but because you're doing it internally, you have faster healing. And there's a thought that because perhaps the muscles which are most involved are those which are interior, perhaps it could be a potentially more effective as well. Right now we have greater than 10 series which are published, but most of these are reasonably small. They're short-term follow-up. Most of these are about 12 weeks, but what's being reported is that symptom improvement is approximately 2/3 of people, and that gastric emptying improvements approximately 3/4. There is a single center prospective randomized trial that was just funded. That's going to be based at Cleveland Clinic, and that's starting in the near future. So hopefully we'll get some answers about this. But right now we have the situation where the data looks very good, but it's almost a it seems like a similar story to what we saw with Botox about 15 years back, and we'll have to see with these studies, which are prospective and randomized, if this bears out. You know, I can say from personal experience, you know, there certainly is a giant placebo effect with doing this. And when patients know that they're getting a GPOM, they're getting hospitalized afterwards, typically they have a modified diet for weeks afterwards, and that's factoring in as well. You know, it's hard to say that there's not a placebo response at this point, given what we know about this response with different trials which have been done looking at medications. And I think we definitely need something that's prospective and randomized to see if this really works. So some of the challenges with this specifically are, you know, one, as I talked about before, they're observational. We need something to see if this works placebo-wise. We do know that this creates a dumping phenomenon as well, and it seems that safety is pretty good with this. But you know, we'll have to see long term, are these patients getting other symptoms which they might not have. And then one question that I think everyone now is wrestling with is there a way to predict who the patients are who are going to get better with this? And you know, as I talked about before, gastroparesis is probably a hodgepodge of different disorders, and it doesn't make sense to think that every patient who gets this done is going to get better. So how can we better, you know, look and identify the patients who are most likely to get benefit? And so FLIP has been looked at as one potential possibility, possible response towards Botox. There was one paper from Ken Cook at Wake Forest who suggested that if you have electrogastrography that's normal, that you are more likely to benefit from this. There's been some literature maybe looking at wireless motility capsule or perhaps duodenal manometry to see if you can identify pyloric pressures and if that predicts. And there's been some thought that maybe satiety testing or a barostat could help. The bottom line is that right now we don't have a clear pathway, and these studies, which are being done prospectively, we'll look hopefully at a lot of these entities and then use that to go back and model and see what works. Then finally, let's talk about gastric stimulation. And there's three ways of doing this. The first one is with Intera, which is placed during surgery. This has been in use since 2003. There's been 2 randomized trials which have looked at it, very similar towards the Botox story. So the first trial turned everyone on or off for 1 month, then switched, then kept them all on for 10. Bottom line is that people improved during the course of the year, but you couldn't separate the on versus the off period. Critics of this said, well, if you can't separate the on versus off, it's hard to say it's not placebo. Proponents of this said it was just 1 month on or off, and it probably takes more time to get full benefit from it. That led to a second study in 2010. Their plan was to do 3 on and 3 off and switch, but the IRB felt it was unethical to take patients who were very, very symptomatic and then not turn things on for at least a brief time. So they then changed it to say, well, let's do 1.5 months off on, and then at that point randomized to 3 on or 3 off and a switch. Very similar to the first study where everyone got better in the course of the year, but you couldn't separate the on or off. Critics of it said, well, if you can't separate the on and off, it doesn't work. Proponents of it said, well, everyone was turned on the first 6 weeks, there's probably residual effect. So bottom line is that it does appear to work in some patients, but this literature is not great, and we don't have a good way of predicting who it does and does not work in. Now, TempStim has been championed by the group at Louisville, and what they've done is they've said, well, what if we could endoscopically place these catheters and then stimulate at home and see if that'll make a difference predicting who does and does not respond towards surgery. So this can be done during endoscopy. You clip these leads in, they then come out the nose. The patient goes home with a battery pack. You give them approximately 5 days and you see. The challenge with it is that we don't have a lot of literature with it. It's tough to get this reimbursed. There's a giant placebo effect with this. And if we believe the randomized trial data, 5 days is probably not adequate really to tell, but it's interesting. And then in the last few years, we've seen these potential non-invasive options. And so the one that you see on the left is a device that's approved to treat headaches, but there are 2 case reports right now looking at this in gastroparesis. The one on the right is one that's in the ear that you apparently can buy via websites online without getting a script. And these are interesting. We'll see where these go. Then finally, let me turn towards unanswered questions and future steps. And, I think if we look at the unanswered questions, the first one is, can we divide gastroparesis into clinically relevant subtypes and not just look at gastric emptying? And I think some of the things that I think are most promising in this are deep tissue biopsy and histology, doing the high-res sort of electrogastrography, looking at perhaps nerve testing to see which patients benefit from stimulation, and then looking at doing biomarkers as well, looking at immunotherapy. What's the link between weight, ghrelin, and gastroparesis? Why is there a gender balance at this point? We don't really know, but women seem to have this about 7 times more often than men. The GPOM story is still, I think, left to be told, but there's good groups looking at that now. Who actually benefits from doing stimulation and how exactly to find that? And then long term, do we have any therapies that can change the underlying nature that aren't just treating the symptoms? So in future directions, I think in the last 15 years, we've seen great studies across centers. We'll have to keep that going. We do need additional workup looking at FLIP and a bunch of these other tests as well. I think deep tissue biopsies in particular are very interesting. We really need not just subsets who are abnormal, but also what's normal. And I think FLIP is a great example of this, where we have 3 studies that have reported different subsets in patients with gastroparesis, but we don't know what people have if they don't have gastroparesis. And so I think we need to first, look at what's normal to then, then really decide what's outside of that spectrum. And I personally think that the ultimate success in treating gastroparesis will probably hinge upon development of tissue banks and really close work with basic sciences as well as likely as immunology. So I will stop there, and thank you very, very much. I greatly appreciate the invite to talk here, and as well, I'm sorry about the slides bouncing back and forth.
Thank you so much, Dr. Clarke. That was great. I feel like gastroparesis is a condition that we see volumes of, and it's always a challenging process trying to really delineate what is the underlying process going on for each of our patients. And it's great to know that there are different therapies that can target different aspects of it. So thank you.
Thank you. Thank you.
We're happy to take any questions and comments from anyone. Feel free to unmute yourself.
I can start. That was great. Thanks very much.
Thank you.
So you talked a little bit, I'll go to the endoscopic part of the world. You talked about, GPOM and so forth. These are very frustrating patients for us. Yeah. So, if you could outline sort of the way that you approach first, medical therapy, you personally approach medical therapy, and then when do you refer patients for endoscopic therapy? I think that would be helpful to us.
Sure. So yeah, that's a great question. When I sit down with patients, I generally go through that slide that I showed looking at what the options are. And I don't show that slide per se, but I briefly talk about, what we have there. And I often, decide how aggressive to be based on their symptom severity and what they've done prior. The subset that I think are getting hospitalized are a small subset of the total bucket. And so a lot of the folks that we're seeing really do have symptoms that are, reasonably mild. And in that group, we're more trying, these meds and herbs and things along those lines, and, looking at, some of the complementary therapies, but we're not necessarily pushing the more aggressive options. For those who have symptom severity that's much worse, I'll try typically something from the medical therapy arms first to see if I can get things better. And I'll say that in the prokinetics, my go-to right now is prucalopride. And then I have had very good experience, I'd say also with domperidone, but it's more of a hassle to do. We have an IRB for it, but there's still a lot of monitoring that we have to do for it. So, and in, those patients that get benefit from it, a lot of them don't want to be on that forever as well. When we kind of go beyond that point, if they're still symptomatic, despite the medications, despite doing herbs, complementary therapies, and things along those lines, then we start to talk about the other options. And I think the GPOM, at least in our pathway, is something that we're moving to earlier than we were a couple of years back. And I did talk about limitations with what we have in terms of long-term studies and randomized trials, but the bottom line is that so far safety seems pretty good. And we do only have one FDA approved med, and that's a med that no one wants to use. So if these patients are completely miserable and we're at the point where we've tried a couple of the different medical arms, they're not getting better, and they are getting hospital admissions, and we then talk about the options, I do think that GPOM becomes attractive in that it may help. Worst case scenario, it's probably not going to make anything worse. And if we're looking at that versus doing stimulation, I feel like because we can do it with endoscopy, it's less invasive. So we are moving towards that a lot earlier now. My general pathway, is I generally will try a Botox injection first, with the idea being that if they get better from it and then symptoms recur again, then I'm more comfortable with that choice of going towards something further. When we do the Botox injection now, we're doing the injection in a 270 around the sphincter. So we're trying to avoid the 6 o'clock position, with the idea that if we do a G pome, it'll be in that area specifically. So if we can minimize any scarring at that point, hopefully it helps. And what my colleagues that do the G-pome here have told me is that, they're generally okay doing it with 1 Botox injection, probably 2. You get beyond 2 and it becomes technically challenging. And, not to say that they can't do it, but they prefer to do it after 1. We generally we'll try 1. We're trying pyloric flip as well, though, the challenge with it is that we don't really know what's normal, and we don't know if the findings that we have with flip really predict who gets better with doing the G-pome. But it makes me feel a little bit better if I can say that they're less distensible on flip, that I send them in that direction. If I do flip and it's completely normal and everything is very wide, and their pylorus expands to greater than 2 centimeters, and they don't respond towards Botox, then I'm not optimistic that sending them to G-pome helps in that scenario. The flip in the pylorus is a little bit of a technical challenge, and so we've had some situations where we just try and pass it down transorally and just kind of direct it with the catheter. Sometimes that works. At times we've tried to snare it, place it in the small bowel. At that point, release the snare and take it back. It's a little more problematic. And then if you have there's one scope, I'm drawing a blank on the size of it, but there's, of the 3 big companies that make endoscopies, 2 of the 3 make a scope that has a channel that's big enough to put the flip in, if you really, really, really stick a lot of lube on. And so we just managed to get that scope actually last week. So I'm looking forward to seeing if I can use that and then direct the flip directly across. I think if you have the capability of doing that, that's probably the easiest way of doing it. We're not really doing electrogastrography here. Ken Cook has a nice paper where in his series, the people who had an electrogastrography that was normal were the group that did great getting any therapy towards pylorus. And so I think if, from kind of a research standpoint, if you had capability of doing that, that's a nice thing to have. We haven't been doing it here. So in my standpoint, usually Botox and flip. And if either they do well with the Botox or the flip looks tight and symptoms come back again, we're at that point usually going ahead. There's subgroups as well that we're more inclined to just push directly with. We've found actually in the lung transplant group specifically, because pylorus spasm is such a strong part of that, that's a group that we push things a little bit earlier if they have gastroparesis. And then in terms of the other things, stent, I'd like that back in the 2013 to 15 range, but at this point G-pome is so commonly done, and it can be done in as short as a 20-minute time. It's made me more hesitant to do stenting with that. And so we are occasionally doing it, but it's more, quite frankly, at this point, in patients who are looking for something to bridge them to, or who have tracked me down based on those papers and want that specifically. And then in terms of a stimulation, that for me is really the people who are nausea predominant, who haven't responded towards anything else. I'll say, to back up a little bit, looking at the endoscopic therapies, my sense is that your symptoms that are going to get better are more of your actual mechanical symptoms in emptying, because you're pretty much inducing dumping. So if you have very slow gastric emptying and you have symptoms of feeling nauseous and full, that's a group that I'm much more comfortable pushing ahead with. If you're someone who has like 11% retention of 4 hours and pain is the main symptom, then I'm not convinced that doing a drainage procedure in that situation is going to make a difference.
Thanks.
Okay, well, thank you very much for a very comprehensive grand rounds, and hopefully sometime in a couple of years, maybe we can get to host you again in person.
I'd love to. Thanks so much. I really appreciate the invitation.
Okay, thank you.